Namaste. Apollo Hospitals Group is India's largest integrated healthcare provider. We have more than 10,000 beds across 75 hospitals with 8,000 clinicians in 55 specialties. We have Cradle, a network of birthing centers, Spectra, a chain of daycare centers, Fertility, a network of IVF centers, 1,300 plus diagnostic centers, a chain of dental clinics, a network of dialysis clinics, Sugar, a chain of clinics for pre-diabetes and diabetes, 260 plus primary clinics, India's largest pharmacy chain that will soon achieve the landmark of 5,000 pharmacies. Apollo MedSkills is the largest healthcare skilling institute in India. UR Life is our wellness platform. Family Health Plan Insurance is a TPA with a pan-India presence and a network of 14,000 plus healthcare providers. Medvasti is Asia's largest and fastest growing health edtech company, having positively impacted the careers of 500,000 healthcare professionals across 192 countries. Leveraging nearly 4 decades of experience, we have designed Apollo Pro Health, a unique AI-enabled personalized health management program. Apollo Home Care has provided holistic care at home to 330,000 patients. Apollo Global Projects Consultancy has been engaged in 54 projects in 32 countries. Apollo Telehealth provides a spectrum of services breaking geographical barriers. Apollo Hospitals Education and Research Foundation, Apollo Research and Innovations, and Apollo Knowledge administer state-of-the-art research and academic programs. For us, clinical excellence is a scholarly approach to clinical practice with passion, passing on this mastery to the next generation of doctors and collaborating to enhance research. Our patient care stands on the 3 pillars of clinical, academic, and research excellence. For us, clinical excellence is giving hope to Mahindra with Nemaline rod disease, who has seen the world upside down his entire life. Mahindra after corrective surgery. For us, clinical excellence is giving hope to this family with conjoined twins that Abriana and Adriana can lead independent lives. Abriana and Adriana after their separation with the founder and chairman of the Apollo Hospitals Group, Padma Vibhushan, Dr. Pratap C. Reddy. For us, clinical excellence is giving hope to the parents of Sanjay with liver failure that after a liver transplant, he will lead a normal life. Sanjay is the first child to have received a successful liver transplant in India at Apollo Hospital, Delhi in 1998. Sanjay had discharge. Sanjay 4 years later. Sanjay 10 years later. Sanjay 15 years later, when the government of India issued a postage stamp marking 15 years of successful liver transplantation in India. 23 years later, Sanjay is now a doctor caring for patients at Apollo Hospitals, Bangalore. The highest rated hospitals are high volume institutions as best outcomes correlate with high procedure volumes. We have India's finest clinicians, hardwired systems and processes developed over 39 years that ensure excellent outcomes. We have performed 200,000 heart surgeries, 300,000 angioplasties, minimal access cardiac surgeries, complex neonatal and pediatric cardiac surgery. Structural heart interventions like TAVI and Mitra clip are routinely performed. We've completed 1 million consults in patients with a malignancy, performed 3,000 bone marrow transplants, established 14 comprehensive cancer centers that provide radiation therapy, medical oncology, pediatric oncology, and oncosurgery, including robotic surgery. We have performed more than 370,000 orthopedic surgeries, including robotic joint replacements. Comprehensive subspecialty services are provided. More than 180,000 neurosurgeries have been performed. All subspecialty services are offered, including robotic spine surgery. From performing India's first successful pediatric and adult liver transplants, first successful combined liver and kidney transplant, more than 20,000 solid organ transplants have been performed. Kidney, liver, combined kidney, liver, heart, lung, combined heart, lung, pancreas, combined pancreas, kidney, and small bowel. Since 2012, every year more than 1,200 solid organ transplants have been performed. Even during the pandemic, 814 transplants were performed in 2020, and now every day, 4 transplants are performed. If any technology is available anywhere in the world, We brought it first to India because India deserves the best, be it cyber knife, robotics or proton therapy. The Proton Therapy Center in Chennai is the only proton center in Southeast Asia. When COVID struck, we deployed a 360-degree approach and launched Project Quach. The Quach experience was published in the NAJM Catalyst. We treated more than 250,000 COVID patients, developed the capability to perform 10 confirmatory COVID tests per minute, participated in 25 clinical trials, and administered 5.5 million vaccines. We ensure that our patients are treated in a safe environment. Our hospital in Delhi was the first in India and the 6th in Asia to get accredited by Joint Commission International way back in 2005. All our major metro hospitals are JCI accredited, which is considered the gold standard in global healthcare accreditation. All our non-metro hospitals are accredited by NABH, the Indian accreditation body. What patients and clinicians want goes beyond accreditation. They want excellent outcomes. We developed Apollo Clinical Excellence, ACE, a clinical balance scorecard in 2008. ACE is a case study at the Ivy Business School in Canada. We have 25 parameters that are benchmarked against the world's best published outcome. Each of our hospitals is expected to be in the green zone for each parameter every month. As an example, the best published survival rate after coronary artery bypass graft is 99.4% from the Cleveland Clinic. If our hospital has a survival rate which is comparable, it gets a score of 4 and 4, but with a mortality of 2.1%, it would get a score of 0. Many hospitals in the world would aim for survival close to 98%, but our hospital would get a 0 at 97.9%. Data from each hospital is reviewed and presented to the board. Remuneration of the CEO, CFO, and medical director has been linked to clinical outcomes. We've developed the Apollo Standards for Clinical Care task that includes ACE, the Apollo Quality Program, incident reporting, mortality review, safe surgery, and ICU checklists. More than 1,000 trainees, 8% of India's national board trainees train in 45 specialties in residency and fellowship programs at Apollo hospitals. We have 2 medical colleges in India, medical school in the UK, 11 nursing colleges, an institute of hospital administration, and a physiotherapy college. Our journal, Apollo Medicine, was launched in 2004 and is published every quarter. We have a robust presence in clinical research with an experience of 1,150 clinical trials involving drugs and devices. We have a biobank, a cord blood bank, and a growing interest in biomarkers and genomics. The Apollo team has worked on the design, development, and deployment of artificial intelligence-based APIs for clinical decision support for cardiovascular diseases, prediabetes, diabetes, liver fibrosis, antibiotics use, COPD, and asthma. Our AI COVID risk score saw 16 million downloads. With 4,149 publications, we have the 3rd highest number of publications in India on PubMed. Our telemedicine network was inaugurated by President Clinton in 2000. From 12,500 feet in the Himalayas to a presence in 48 countries. From e-urban healthcare centers to teleophthalmology to digital dispensaries, to an e-ICU program, to teleradiology through Apollo Radiology International providing radiological services across India and beyond, to digital pathology linking pathologists across India covering 13 subspecialties of pathology. 13 million lives have been touched through Apollo Telehealth. Based on the learnings of 22 million health checks, ProHealth, the AI-enabled personalized health management program, has shown impressive improvement in clinical parameters of individuals through personalized, proactive, and timely interventions. Apollo 24/7 is the fastest growing health care platform in India with over 17 million users across 450 cities. This new age end-to-end omni-channel platform offers a full bouquet of healthcare services, 24/7 consultation, seamless medicine delivery at home across 19,000 PIN codes, diagnostic test booking, and doorstep sample collection, digital health records, and more. The Apollo Total Health Program in Aragonda and surrounding villages in the state of Andhra Pradesh for a population of 70,000 people, encompassing physical, mental, and social health, ecology, Spiritual well-being and economic fulfillment is now a case study at the Harvard T.H. Chan School of Public Health. Many honors have come our way, including 2 case studies from Harvard Business School, international and national awards and recognition. The greatest honor is that 4 stamps have been issued marking our achievements. 25 years of service to the nation, 15 years of liver transplantation in India, performing 150,000 open heart surgeries and completing 20 million health checks. We are privileged to have earned the trust of 200 million individuals from 140 countries. Thank you.
Welcome to the Summer Apollo Cancer Care Symposium. This is the 3rd installment that we have done from Durban 2 nights ago. We had a very, very good audience that graced that event for us. Last night we were in Cape Town, engaged with some doctors in there to actually share some of the breakthrough technologies that we are bringing today. I'm going to be introducing the program, and I'll allow our CEO, Dr. Vusi Nhlapho, the honor of welcoming our dignitaries that are in this room today. The program is going to be Dr. Vusi Nhlapho doing the welcome, and then we will have our dignitaries doing the welcome and being acknowledged. And then we have 3 very great presentations today. Dr. Duvern Ramiah will be doing the presentation straight after our dignitaries. And then we're going to have all the way from Morocco connecting to us, Professor Llewellyn Padayachi from University of Pretoria. He is in Morocco at the moment, but will be connecting with us today. And our keynote speaker as special guest all the way from Apollo in India will also be presenting Dr. Srinivas Chilukuri. Then we request that people who are connecting online, and if you have any questions, just keep them towards the end. We will have again Dr. Vusi Nhlapho coming up here to be able to run the Q&A session, and then we'll have closing from Dr. Vusi Nhlapho. Dr. Nhlapho.
Good evening, colleagues. Let me take this opportunity to welcome you all, those who are here present and colleagues that will be joining online to this very special event that is being hosted by the SA Medical Association in collaboration with the Apollo Hospital Group. It gives me the greatest of pleasure to have collaborated with Apollo on a number of fronts. Firstly, as you would be aware, Apollo is from India, and I wanted to spend a bit of time talking about that significance of that location. Colleagues would recall and reminded that India is our partner in the BRICS community. This means that we have a number of similarities that we share with India. These are at the level of economic development. Some of the issues that we face with regard to the socio-economic challenges that we're dealing with. We have a number of similar health challenges that we are facing as both countries. It therefore stands to reason that with all those similarities and some of the health challenges that we're facing, we have an opportunity to learn from each other as partners. It therefore is a great opportunity to have this initiative, which will engage the medical fraternity with the Apollo group, focusing particularly on the proton beam therapy. I know that some of the colleagues would be very much au fait with this treatment modality, but also then I know that there would be colleagues that would be introduced to this treatment modality. Either way, what we are hoping to do as the association with this initiative is to start, in some cases, the conversation about proton beam therapy, but also then possibly enhance the debate around this treatment modality. As a result, our focus tonight will be on the clinical findings. Apollo has had a longer journey on this treatment modality. We will listen to what their experiences are and see what would be transferable or could be applicable to the South African environment. Those lessons are important. I am hoping that that starts the conversation in terms of this treatment modality. But more importantly, as we engage with the topic, we would then bring on board a number of other important disciplines. Health economics would be important. Government departments would be important. Colleagues in the private sector and who are running private hospitals would be important. And I think as we then deliberate on how we take this discussion forward, we need as many voices as possible. So I anticipate that as we engage, coming from different perspectives, we should be in a position to ask some of the very difficult questions. Is this a treatment modality that we need to be talking about in this country? With all the challenges that we're dealing with in as far as health challenges are concerned, should we be even be looking at this as a treatment modality? One of the things that is clear is that even though we are a middle to middle income country as India is, if you look at the data over the last 10 years or so, what is very clear is that there is an increasing incidence of cancers across the board and affects all different demographics. So I think this is a timely conversation. And I think at some point, we should be in a position to engage with this as a serious issue in the country. As indicated, we've got two local speakers and looking forward to their input, Dr. Ramiah, as well as Professor Padayachi as well. I'm looking forward to the presentation. And I've had the joy of listening to Dr. Chilukuri over the last 2 times. I'm sure you'd love the conversation and hopefully we'll give you something to think about. But before we do all of that, then let me take this opportunity to welcome one of the special guests in tonight's event. And that is the Second Secretary to the Indian High Commissioner here in South Africa, Mr. Dhirendra Kumar. So please join me in welcoming Dr. Kumar. Please come. We will do just a few words.
Thank you very much, CEO. A very good evening. My name is Sudhir Mani from the High Commission of India based in Pretoria. I would like to welcome the Apollo Hospital Group to South Africa and wish them well in their endeavors in South Africa to make it a success. The proton therapy is quite well advanced, and I certainly hope that South Africans do take advantage of that treatment. Just very briefly on India-South Africa relationships, we go back since 1993, when the first High Commission was established in Pretoria in 1993. Our bilateral trade as of date is $17 billion US, which is in the favor of South Africa. In terms of exports from South Africa, it's a lot of commodities like coal, gold, diamonds, other commodities like iron ores, etc. From India, the exports automotive vehicles, manufactured goods, cellular phones, etc. By far, the largest export is automotive vehicles and components, which is really doing well in South Africa. You'll see on the roads, it's Mahindra vehicles, Tata, etc., and it's growing. In fact, it's the largest import into South Africa from across the globe. And in terms of other opportunities that we are exploring, it's training. We have the Gandhi Mandela Training Institute in Pretoria, which is a collaboration with the TVET College in Pretoria, which provides training in the domain of boilermakers, welders, artisans, etc. And we hope to replicate that in the other centers in South Africa, in the other TVET colleges in South Africa, in Cape Town, Durban, etc. The relationship, as you know, is growing day by day. This year is BRICS, which is taking place in August. And we also hope to further grow that relationship as well with other countries as well, and also look at opportunities and what we've done in the past few years to grow on that. Okay, and then this year as well, India is chairing the G20 presidency, and we have a number of initiatives that are taking place in India this year. A number of South African government departments have been to India so far to look at opportunities and take part in thought leaderships in India. So we hope to really grow that. And in terms of other opportunities, you know, we hope that the initiative of Apollo Group will really grow the medical initiatives in South Africa. There's a number of opportunities which can be leveraged, and we wish them well in the endeavors. Thank you so much.
Thank you so much. Dr. Duvern Ramiah, he is the head of radiation oncology at the University of Witwatersrand, as well as head of oncology at Charlotte Maxeke Johannesburg Academic Hospital, as well as being involved in private practice at the Wits Donald Gordon Medical Center. He attended Wits in Johannesburg and graduated with a medical degree in 2002. He specialized in radiation oncology, and upon graduation as a fellow of the College of Radiation Oncologists of South Africa, he continued to work for a further 2 years at the State Academic Radiation Oncology Unit. In 2016, he pursued his MBA at the world-renowned London Business School in England, where he graduated with a distinction and started his private practice at the Wits Donald Gordon Medical Center. He's currently involved in a startup oncology in Dunkeld, Johannesburg. He always appreciated the importance of serving others and did not hesitate in accepting when called upon to take on the role of clinical head of the Department of Radiation Oncology at the Charlotte Maxeke Hospital. It is the main oncology teaching hospital of Vets Medical School and was soon after named academic head of the department of the said university. He has been involved in many scientific publications, most recently in breast radiation therapy in high impact international journals. He has an interest in prostate cancer as well and introduced prostate cancer brachytherapy program at both the Charlotte Maxeke and the Chris Hani Baragwana Academic Hospital, which is one of the second largest hospitals in the world. And he has received several awards from the Center for Public Sector Innovation. He is an International Education Committee member of the American Society of Radiation and Oncology, called ASTRO, an examiner of the Colleges of Medicine of South Africa, an executive committee of the South African Society of Clinical and Radiation Oncology, is called SASCRO, and sit on the editorial board of the South African Journal of Oncology, SAJO. He is also an executive board member of the Breast Interest Group of South Africa, BIGOSA, the Medical and Scientific Committee of the Prostate Cancer Foundation of South Africa, and the Gauteng Department of Health Cancer Task Team. Without further ado, Dr. Ramiah, please join us.
Thank you. Thank you very much for that introduction. So, yeah, I think as been mentioned, I'm Duvern Ramiah, radiation oncologist at WITS, and so this evening I'm going to talk about a subject which I think is becoming more and more topical, and I'm going to discuss why just now. But proton beam radiation therapy. Okay, so proton technology, as with most radiation technologies, is evolving and improving. And with this improvement, it's becoming cheaper to develop proton centers. Although I must qualify that by saying that even though it's becoming cheaper, it's still by no means cheap. So this technology, which was previously available in only a few select units globally, is now becoming available in a growing number of centers. And as the price of building these units is reducing, the treatment price drops, and it has the effect of it becoming more accessible. So much like how expensive mainframe computers were disrupted by PCs, and then PCs were disrupted by mobile devices, the overall effect is that more potential users have access to the technology. So we're seeing the start of a similar trend with protons. And as doctors, we should know who to consider this treatment for, and also how to respond to queries when patients ask us if they are candidates for proton therapy. So my overview of what to expect tonight is I'm first going to discuss some proton therapy basics, and then we're going to briefly touch on the data supporting its use, and given this, how we should approach it in a South African context. Like I've already mentioned, it's important that we look at it as a possible option to add to our arsenal of radiotherapy treatments, because as fortune cookie wisdom tells us, many a false step was made by standing still. So just some basic radiation here. There's different ways to improve radiation outcomes, and these are not mutually exclusive. You can improve the dose distribution, which is called the ballistic selectivity. And here you improve the dose to your tumor while reducing the dose to the normal tissues around it. Or the other thing that you can do is you can play with the differential response of the tumor and the normal tissue to ionizing radiation, which is called the differential effect. So those familiar with some basic medical physics and radiobiology will know that photons or X-rays have a dose fall off in normal tissue, and you can see the typical way they fall off on the top black line. But if you use protons, which you see in red, you see very little dose is delivered until you reach the Bragg peak. Then the protons have slowed and stopped traveling, and then they deposit all their energy at that depth. I'll also just mention carbon ions have a similar Bragg peak, but they do deposit some dose after that. It's that area in pink on the graph. And I'll mention it 1 or 2 times. I'll mention carbon ions 1 or 2 times in this talk, just because there is a bit of interest in it currently, and it may have some advantages over protons in some radiation resistant tumors. So by using protons or carbon ions for that matter, you definitely spare normal tissue after the Bragg peak, which is the area seen in dark green. You can also spare some tissue before the Bragg peak. But tumors are typically thicker than 1 to 2 millimeters, so you need to spread out that Bragg peak. I'm not going to go into the technicalities of how that's done, because I'm not a physicist or an engineer, so I won't do it justice. But I'm just going to say that the Bragg peak can be spread out. And if you spread out that Bragg peak, you still end up with a lower dose to the normal tissues in front of the tumor, as shown in the green area. And you obviously spare tissue after the tumor, which is the area, the green area after the red part of the Bragg peak. And then if you use multiple beams or intensity modulated proton therapy, you get an even better dose distribution than this. So this shows so it shows beam scanning, which is a newer method of stretching out that Bragg peak, as opposed to passive scatter, which you see there on the bottom image, which was a method used in the past. So what you see here is a single beam coming from the left. With the older passive scattering, you see that you can still spare some tissue after the Bragg peak, but there's still some dose delivered in front of the tumor. But with beam scanning, you can spare tissue in front of the tumor as well as tissue after the tumor. And again, like I said, this is with a single beam, but in practice, you can use more than 1 beam. The reason I mention this is because with IMRT or VMAT technologies, in the sophisticated new linear accelerators that we have at Wits Donald Gordon, or even Charlotte McKerker for that matter, the radiation plans that you get and the conformity with them is almost as good as the old passive scatter proton plans. But in order for proton plans to still maintain their dosimetric advantage, you need to go to a unit where they have pencil beam scanning or intensity modulated proton therapy. So I think it's important when you send patients over for proton therapy that it's at a unit that has the newer proton technology. So what I've just discussed now is the ballistic effect, which I've explained earlier, looks at the accuracy of the tumor and increasing the dose of the tumor while decreasing dose to the normal tissues after it. I'm just going to quickly touch on the differential effect as well. The non-oncologist can probably ignore this in the next slide, because it very much pertains to the technicalities of radiation. But protons have almost the same linear energy transfer as photons. So you can't use protons to improve the differential effect over photons. And in general, what that turns out is that protons have almost the same dose and the same number of fractions that you would use with photons. And this has become of interest around the world, because carbon ions, like protons, are charged particles of the Bragg peak, but they have a very high linear energy transfer, which means that they deposit more energy as they pass through the tissue. So tissues which are very resistant to radiation are less affected by photon or proton radiation than healthy tissue, like seen in that graph on the left. And that is, like, for example, some salivary gland tumors or sarcomas. In those cases where you get these very, very resistant tumors, there may be a benefit to using high LET particles like carbon ions. And with this high LET radiation, you can reduce the differential response between the tumor and the healthy tissue, and you can increase your response to the tumor. But that's only a very small minority of tumors. As we all know, most tumors are more sensitive to radiation than the surrounding tissue. So you prefer to use low LET radiation like protons or photons because you want to maintain that differential response between the tumor and the healthy tissue to radiation. And you lose that with high LET radiation like carbon ions. So in short, theoretically, protons are better than carbon ions for most tumors. But we also need to just keep in the back of our mind that the biological effect of protons is thought to be similar to photons, but there is some uncertainty around this. And whether it does exert the same biological effect on the tumor is somewhat controversial. And the amount of data we have on protons is less than we have with photons. So getting more practical, in the past, the production of protons required huge machines. This is the gantry of a proton unit in Zurich. And you can see from this picture, it was massive and weighed a few 100 tons. And this is a picture of the first IBA machine in Boston. And you can see it's somewhat more compact and it allows for better patient positioning, planning, and treatment delivery, but it was still part of a large, very expensive setup. But more recently, IBA and Siemens Varian discovered a more compact solution for producing protons, and it allowed facilities to be built at a fraction of the price that it would have previously cost. So it's dropped from a few €100 million to now about 40 million euros for a single room facility. So it's still, we're looking almost at R1 billion to build one of these units, for example, in South Africa. So to make it feasible in the private sector, if we were ever going to consider building such a facilities, medical aids would need to start reimbursing a lot more, or we would need a lot more patients to use the facility. And let's be realistic, I don't think that's going to happen. So, in patients that have a clear benefit to have proton therapy, we need to send them to facilities overseas. The cost per patient previously was about $200,000 for treatment in the US, but now treatment in countries like India, the Apollo unit is significantly cheaper. So it makes this treatment a lot more accessible to more people, especially in South Africa. So as I mentioned in the start, low energy protons have been around for a long time. And it was initially used to treat ocular melanoma. So this is a treatment that was done a very, very long time ago. But you can see even in those treatments, for a very thick melanoma, you get a very exquisite dose distribution of using protons, which spare the optic nerve and the macula from radiation. This is an example of a very large Ewing sarcoma of the pelvis. And you can see the IMPT plan at the top versus the IMRT plan at the bottom. And you can see, and I don't think you need to be a radiation oncologist to see that there's a lot of extra dose being delivered to the normal tissue in the bottom plan, which is the IMRT plan. So in that case, the bowel, for example, will be getting a lot more radiation. So there's benefit in terms of the acute and long-term side effects from using proton therapy because you get less radiation being delivered to your normal tissues. So here are some of the indications for protons at the moment. I took this from an Australian publication from Huang et al. In 2020. So they're developing a proton unit in Australia, and they did a few studies on the areas that it would be beneficial in. So you can see here that there's not a lot of data from randomized controlled trial. The majority of the data was from comparative cost studies. But you can see they've looked at a lot of different sites, and most of the data is in pediatrics, followed by ocular tumors, then head and neck, sarcoma, GIT, thoracic tumors, and the breast. This is another table of indications for protons, which was taken from a publication from Herman Soot in 2010. And he's probably the radiation oncologist with the most experience with proton treatment. And what he basically said was that all tumors could benefit from protons, because if you decrease the radiation to your non-target tissue, you get less side effects. So I don't think any of us would disagree with that, but you do need evidence to back this up. And given the high cost of protons, the benefit needs to be definitive. So the benefit ideally should be proven in a randomized controlled trial. So for some pediatric lesions, it's basically accepted that protons are the preferred treatment. Also for some skull-based chordomas, chondrosarcomas, head and neck, paranasal sinus tumors, non-operable lung tumors, hepatic tumors, pelvic chordomas, chondrosarcomas, pediatric brain and spinal cord tumors, orbital and ocular tumors, and sarcomas at the basis of the spine and skull. You absolutely, would use proton treatment as your treatment of choice if it was available. And there is a proven benefit over IMRT. And moving on from that, this is a trial from Gratis et al. Who showed the benefit of protons over 3D chemoradiation for non-small cell lung cancer. But however, interestingly in this trial, when they compared it to stereotactic body radiosurgery, they didn't actually show a benefit which was clear. But there's a large number of ongoing trials internationally in different sites to show the clinical benefit of using protons. And hopefully we can have some definitive answers in these trials soon. So with more protons units popping up globally with huge debt to pay down, some may feel driven to use the proton hammer for all nails. However, as we move towards value-based medical practice, the evidence-based judging protons must be adjudicated. It's not good enough to say this is a sharp knife without formal testing. And like I mentioned earlier, protons do introduce some radiobiological unknowns. But saying that, in some situations, the benefit is intuitively clear, such as in pediatric tumors, and trials in those areas may even be seen as unethical. In other areas, the benefit is non-existent, like in skin cancers, for example. But there is this gray area where the advantages and disadvantages are not yet known. And for these, there are trials underway, but the current evidence is somewhat thin. And like I've said here, our knowledge is a bit like the Platte River. There's a lot of areas that we've looked at protons being used in, but still, it's a mile wide, but an inch deep. So what do we do in the meantime as radiation oncologists when we have a patient who we feel may benefit from protons? So my approach when we have a patient we're considering for protons is I generally have a meeting with the radiation oncologist at the Proton Center and we compare our plans and dose distributions. If we were using normal tissue tolerance when using normal tissue tolerance comparisons, the benefit for protons may reduce the long-term toxicity. And if this is clinically significant, then we should use protons. This is the case of a patient I saw last year. Master K is a 15-year-old gentleman who's referred to me by a pediatric oncologist with a low-grade infiltrating glioma. He initially presented with decreased movement, impaired vision in his right eye, for which he consulted an ophthalmologist. He was then referred for an MRI brain in June 2019, which showed diffuse brainstem glioma in the midbrain and pons. Initially, it measured 2.8 by 2 by 2.5 centimeters, although these are the scans I put up here of the MRI did just prior to planning his radiation when the tumor had grown a bit. So after the initial MRI, he had a biopsy done in August of 2019, which confirmed an infiltrating low-grade glioma. Molecular pathology confirmed a NTRK2 fusion. So management subsequently was observation only, and there was a very slow growth of the tumor over the next couple of years with no worsening of symptoms. He was then started on larotrectinib in February 2022, but he developed some mood side effects to the tumor with to the larotrectinib with no reduction in the tumor growth. So it was decided to stop the treatment. His MRI in May 2022 showed the tumor had grown to 3.4 by 2.7 centimeters, and then he was then referred to me for radiotherapy. I discussed various options with Master K and his parents. I discussed the plan with the radiation oncologist at the University of Florida. So we did his radiation planning scan in Johannesburg, and I did the contouring in Johannesburg. And then the Florida oncologist then went on to do a proton radiation plan, and I did a plan in Johannesburg using a volumetric arc treatment plan at Fitz-Donald Gordon. So this is the comparison of our two dose volume histograms. The protons were obviously showed a significantly less dose to some of the organs at risks, significantly the cochlea, the hippocampus, and the circle of Willis. But ultimately, the VMAT IMRT plan was all within tolerance. And after a long discussion with the parents, they're feeling that the benefit to the protons was clinically uncertain. And even though the Proton plan looked better on paper, it didn't justify them spending approximately 3 million Rand on a Proton treatment in the US. So ultimately, he had treatment in Witwatersrand Gordon. So the way to ultimately decide on whether you want a patient to have Proton treatment is sort of follow a similar algorithm to what I've just discussed. In a patient who will definitely benefit from the Proton treatment, go ahead and give them Proton treatment. If there is no benefit to Proton treatment, then go ahead and do volumetric arc treatment or any sort of photon treatment. But in the patients that we are unsure of, what we should do is have a clinical trial where we randomize patients to receive either protons or photons, and then we can see what the actual scale of the benefit is. So this is the Dutch model, which is followed in the Netherlands, and it forms the basis of some of the ongoing trials comparing protons and photons. There's a Danish trial called Den Hacker 35, which is looking at the benefit of protons versus photons in larynx and pharynx cancers. There's the PROTECT trial, which has a similar design for esophagus cancer, and the Imperator trial in head and neck cancers. And this is the study design for the Imperator trial. And here, as you can see, the patients that may benefit from protons or photons are then randomized to receive either of these treatments. So in conclusion, protons could represent a way of improving radiotherapy outcomes, mainly by decreasing the toxicity, but the proven benefit is not in all sites. There's a number of randomized control trials going on currently to establish benefit. But in the South African context, where we are resource constrained, we need to evaluate if the scale of the benefit is worthy of the cost. So I'll end with a quote from Warren Buffett, where he says, "Price is what you pay, value is what you get." The price that each patient is willing to pay for the potential value add will vary from patient to patient. But I think it's important for us to have that discussion with patients who may benefit. Thank you.
Thank you, Dr. Ramiah. Our next speaker, as I indicated, will be connecting to us via Morocco, Professor Llewellyn Padayachi. He's a professor and head of neurosurgery at the Faculty of Health Sciences at the University of Pretoria and the Steve Biko Academic Hospital there. He started out as a pediatric neurosurgeon in 2009 at the Red Cross War Memorial Children's Hospital at the University of Cape Town. He practiced there for 7 years, and then he was appointed as a Hamilton Naki Scholar at the Department of Clinical Neurosciences in the functional MRI of the brain unit at the University of Oxford, which we did in 2017 to 2018 in the UK. As I indicated, that he heads the Department of Neurosurgery since January 2019. He's a specialist pediatric neurosurgeon, as I've indicated, and also an adult brain tumor surgeon. His special interests are minimally invasive surgical approaches and also intraoperative adjuncts in brain tumor surgery. Without further ado, can we get Prof to join us from Morocco?
Thank you very much. Can you see me and hear me?
Yes, we can. Thank you. Please go ahead.
Okay, thanks very much for that kind introduction, and just an acknowledgement to the senior staff of SAMA, the fellow speakers, and all the dignitaries present. So the reason I decided to present the talk from you rather than the one I forwarded to you was following on Dr. Ramiah's talk. I tried to modify it so that my interest and perspective and at least would balance to some extent, what you'd said. I think sort of the basic understanding of proton beam therapy is something that you'd understand better than I would. But in terms of the treatment for pediatric and adult brain tumors, there are certain things that stick out. And I wanted to just highlight the fact that the brain is innately, a neurological structure that is very sensitive to radiation, particularly the developing brain. So kids, like you pointed out, I'm a pediatric neurosurgeon, and my main interest is in operating or surgically treating as part of a multidisciplinary team. Children with brain tumors, and now also, as you quite correctly pointed out, more and more adult brain tumors. So it's important to realize that this radiation exposure to the body, but to the central nervous system is not limited to just treatment modalities. So the environmental factors expose us to quite a bit of electromagnetic radiation, and I'll touch on that a little bit. Diagnostic modalities also expose, particularly the developing brain, to a significant amount of radiation. The developing nervous system is exquisitely sensitive to this, especially the cumulative dose over the lifespan of a child is something I've spent a lot of time trying to and the other system exposure as well, particularly the hematopoietic and endocrine systems as well, in terms of treatment are important factors to bear in mind. So some of this has been mentioned, and this is not meant to be exhaustive at all, but radiation energy could be electromagnetic or particulate. Therapeutic radiation is a very basic approach to it, is high energy, so linear accelerators, like was mentioned previously, external beam radiotherapy, and I'll maybe just touch on that a little bit. I wasn't sure whether to leave that as part of my talk or not, but I will show just some of the options that are available and why proton beam therapy, particularly for certain types of radio or brain tumors, may be particularly useful. So as many of us may or may not know, electromagnetic radiation exposure in the environment is quite an important issue. If you look at just cell phones and base stations, for instance, they emit electromagnetic radiation continuously, particularly in rural areas where the output is much higher. They need to cover larger areas, so these cell phones work harder. The effort to convert 1G to 3G, all of these demand that the units emit a higher electromagnetic radiation. And there's been quite an interest in terms of what these cell phones and other electromagnetic radiation devices expose the brain to. And there is some evidence to suggest that because of the anatomical and the sort of age of the patient involved, certain types of tumors in certain areas, so temporal lobe tumors, insular regions, kids where the scalp is thin, the skull itself is thin, the parotid region, and also the type of phone. And this has been modified over years. You may wonder why the antennas and a lot of the cell phones have disappeared, and that was in an effort to decrease this electromagnetic radiation. And the image I've shown on the left just shows the depth of penetration from these radiation fields in younger kids as opposed to older kids. So it's something that we need to bear in mind. And this was something the International Agency for Research on Cancer, part of the WHO, looked at. And their recommendation was quite interesting. To summarize that, they felt even though the evidence is limited, certain types of electromagnetic devices do have a propensity or relationship with higher glioma and acoustic neuroma incidences. At that time, the evidence was inadequate to draw conclusions, but they felt that there could be some risk, and therefore we need to keep a close watch on this link between certain types of electromagnetic radiation and cancer risks. To that effect, certain organizations like Sick Kids based in Toronto issued certain warnings for how we should use these electromagnetic emitting radiation devices, particularly in kids. And just to make the list a little exhaustive, I've added studies that are ongoing looking at this relationship. So the point I'm making here is that radiation is not just therapeutic effort. The environmental exposure is something we must be aware of, even diagnostically. So the effective dose calculated in millisievert. A chest X-ray exposes us to 1 day's worth of background radiation. Skull X-ray, 5 days. CT scan of the head, 8 months worth of background radiation. So one CT scan exposes you to the same radiation dose as 100 chest X-rays. And at least a third of the children that we treat with pediatric neurosurgical conditions will have, at least 3 scans. And what does that mean? So a study published in the Lancet also made the front page of the New York Times, looking at 175,000 patients, showed that a child under the age of 15 having 2 to 3 CT scans had a triple lifetime risk of brain cancer, 5 to 10 scans under the age of 15, triple the risk of leukemia. So these are things that are important. And if we look at anything from any children's hospital, this is a 6-month-old who had 15 CT scans, in the course of 5 months. So this, perhaps, I hope anyway, creates some sort of background in terms of the relationship between radiation and the brain. The fundamentals were mentioned previously, so I'll skip over this in the interest of time. But as a neurosurgeon, pediatric neurosurgeon particularly, I think my role in terms of treating children with brain tumors, more and more I've appreciated the fact that as part of a multidisciplinary team, that's probably the best value proposition one could provide for these patients. So that the full multidisciplinary team would be, neurosurgeon or pediatric neurosurgeon, depending on the age of the patient, an oncologist, radiation oncologist, a good neuroanesthetist, a neurocritical care, adequate pathology, both in terms of histological and molecular profiling, if that's available, imaging, so CT scans, MRI, and nuclear scans, depending on whether you need those, and then neurorehabilitation, which is a fundamental part of optimizing outcomes. So the neurosurgery theater these days is quite a complex space. So we've got lots of equipment, adjuncts to fine tune the way we remove these tumors, neuronavigation systems, there are minimally invasive techniques, the microscope, the endoscope, endovascular techniques to occlude the blood supply. And this is part of treatment or to make the surgery less hemorrhagic. There are novel ablation techniques, intraoperative image guidance ranging from MRI to CT to fluorescence guidance to intraoperative ultrasound, and these combined with intraoperative monitoring techniques, so cortical mapping and neurophysiological monitoring techniques, whether awake or asleep. These things in combination basically try to make our approach to managing tumors or brain tumors, depending on where they are in certain eloquent structures, like we saw previously, that the brain stem tumor, that's not an operable tumor, but where we plan to remove tumors like that, you want to do it in the safest way. And this I'm highlighting as part of the surgical contribution to optimizing outcome. So this is just a sort of graphic or image representation. The navigation is like a GPS for the brain. Intraoperative imaging, whether you've got, esoteric structures like intraoperative MRI or intraoperative ultrasound, enhancement or optical or imaging techniques like 5-ALA, and then combining these with monitoring and mapping, are all efforts to optimize the degree of surgical resection with a goal of maximal safe surgical resection of these tumors. And then, adjunctive treatments like radiotherapy or chemotherapy come into play. And there are timelines which I'll show towards the end. But this holistic care of patients with brain tumors, I think, is fundamental. This is just a structure of what the navigation systems look like. This is the case I wanted to show of a child, a 3-year-old kid with what turned out to be a supratentorial ependymoma. You can see quite an extensive tumor, which we did quite a nice resection on, but there was a delay in terms of giving the kid radiotherapy. And by the time we repeated the imaging, you can see there's already some sort of recurrence there. So this just highlights the fact that this flow, brain tumor boards or pediatric brain tumor boards are fundamental, and these patients need to be discussed in the context of such a multidisciplinary team. Okay, this is an image showing, a kid with a brain tumor, what turned out to be a medulloblastoma. This is our intraoperative imaging. You can see during the surgery, a little bit of tumor left. Ultimately, we remove the whole tumor. That's looking at the floor of the brainstem all the way up to the aqueduct. So good surgical resection is fundamental, but getting these kids to radiotherapy, depending on their age, is just as important as I showed with the previous recurrence rate. Again, just showing a kid with a complete resection versus one where we monitored and realized it wasn't safe to remove all the tumor against the brainstem, so we left some tumor behind. So again, depending on the molecular profiling and the type of tumor, these are kids who need to get radiotherapy. So the types of tumors that are susceptible or indications for radiotherapy, there's a big list of them, and I think some of these were covered in the previous talks. I'm not going to go over them in any sort of exhaustive way. What I want to highlight is the curative potential of radiotherapy, and you look at it almost or not almost, a select group of brain tumors, survival is significantly improved with radiotherapy. In children particularly, I've highlighted a few. So craniopharyngiomas, you can see the surgical resection combined with radiotherapy. There's no argument that the survival rates are better and the recurrence rates are lower. Neurocognitive functioning, particularly in craniopharyngioma, is something, and I'll show this a little bit later, that this performance certainly seems to be better, with the use of proton therapy. And this will potentially highlight the use of this in pediatric and adult brain tumors. One of the more common tumors that we see in kids, medulloblastomas and ependymomas, if you look at the doses, depending on what sort of threshold one uses, the evidence seems to sit quite heavily within a specific treatment regimen, which is used fairly standardly now in most centers treating high volumes of children with brain tumors. The radiotherapy techniques, I think some of it was touched on, and I'll just go through them fairly quickly just to summarize them from a kind of neurosurgery point of view. So stereotactic radiosurgery, I'm not going to go through the details, but there are certain indications. So you're looking at small tumors, AVMs, trigeminal neuralgia, and that basically selects out most of the tumors that or the conditions that are suitable for this type of radiotherapy. Gamma knife versus cyber knife, which is a different discussion that we'd also had previously. Depending on how one looks at it, the one is just sort of radiation beams focused on the tumor, hundreds of small angles. Each beam is weak but converges on the tumor. Compare that to the mobile LINAC that moves around the head and delivers radiation from many sort of computer-controlled angles. Stereotactic radiotherapy, again, has certain indications. You can treat probably larger tumors than in just stereotactic radiosurgery, but again, very specific and comes with certain side effects. Immune modulated radiotherapy, which was mentioned earlier, which is something used in again, high volume centers, mostly academic centers, has been quite attractive in terms of the outcomes published from this type of technique. And then not just the brain, but the spine as well. So craniospinal radiotherapy, particularly in kids with medulloblastoma who have drop metastases, a disseminated disease, when MRIs of the spine or lumbar puncture confirms that, the dose of radiotherapy for these kids differs. Brachytherapy, I think, was mentioned in the previous talk as well, but this has been flagged as a useful adjunctive tool in resection of brain tumors, where this, the sort of radiotherapy material is placed directly or near the tumor bed and delivers the dose of radiation. 3D conformal radiotherapy, again, was mentioned, and this is all in an effort to shape the beam around the tumor itself and limit damage to surrounding tissue. And that perhaps brings us to the crux of the talk, and why proton beam radiotherapy, particularly in brain tumors, is thought to be an attractive modality. There have been several advances in treatment planning. I think most of them have been mentioned in the previous talks. I won't go through them, but I think the early side effects of radiotherapy and the late side effects are probably where the difference between standard radiotherapy techniques comes into play. Things like irritability, fatigue, there are ways of managing them, hair loss, cognitive impairment, particularly in kids, as a cumulative dose over the lifetime of the child. Memory and personality changes have been described. In kids, those under the age of 3 years are considered not really candidates for radiotherapy. Some would, do it at a slightly younger age, but generally in kids under this age, you want to tie them over with chemotherapy until the age of 3. So that's also an important factor to take into account. The later side effects of radiotherapy, things like radiation necrosis, the increased risk for developing another tumor, and vascular injury, particularly conditions like Moya-Moya phenomenon in kids and in patients who have neurofibromatosis, are things to bear in mind. So conformal proton beam radiotherapy probably comes into play here, similar to the 3D radiotherapy, but these protons, and I think for me, the simplest way to understand them is that they release the energy before and after they pass through. So protons are thought to cause less damage to the tissue. They pass through and release their energy only after they travel a certain distance. And these images, some of which were shown in the previous talk as well, basically highlight the value that this energy is delivered, so it delivers potentially higher volumes of radiation to the tumor itself and causes less damage to the surrounding tissue. The limitation, as is pointed out, is they're tremendously expensive. They're limited centers offering this this service, and in a sort of context like South Africa, there are several limitations and potential benefits that I will highlight towards the end of the talk. In adult brain tumors, it's supposed to deliver excellent dose localization. Specific tumors that have been shown to have some benefit are things like certain types of meningiomas, low-grade gliomas, certain high-grade gliomas, skull-based tumors, chondrosarcomas, and chordomas. In fact, for chordomas, protons were described to be the standard of care. That may be the way a lot of these things are headed, but like I said, there are very specific limitations one needs to bear in mind. In children, pediatric brain tumors, I think just as a reminder, the commonest solid malignancy in children, multimodality therapy for me, probably more important than anything else, forms the pillar of treatment. So you want to have maximal safe tumor resection, and I highlighted that previously. There are ways that we do that as neurosurgeons or pediatric neurosurgeons to remove the optimal volume of tumor, but not leave the patient with any additional neurological deficit. Then you want to minimize the side effect profile of radiotherapy and other sort of adjunctive treatments. And then intensive neurorehabilitation again comes into play. So the things that you'd look at are lower rates of late toxicity, which have been described in several papers. I think one of them was highlighted in the previous talk as well. Pediatric brain tumors, I've given the list: low-grade gliomas, ependymomas, craniopharyngiomas, medulloblastomas. You want to limit damage to the hippocampus, hypothalamus, surrounding structures, the cochlea as well. And the goal is to try and preserve as much as possible cognitive function, limit endocrine damage, and preserve hearing as best as possible. So to summarize a lot of that, then I think radiotherapy and proton beam radiotherapy as a part of that form a fundamental part of the adjuvant therapy of brain tumors. There's specific indications, especially in children, and one needs to tease that out in the context, geographically, economically, or socially, depending on how you want to separate those. So several advances in research avenues we also need to bear in mind: treatment modalities that are chemotherapy-based, immunotherapy, viral gene therapy. All of these things, one needs to factor them in terms of their value and cost, their cost and value proposition, and how they delivered, whether adjuvant or neoadjuvant, is also an important consideration. For me, the most important tool is that these things are discussed, like this forum has created, in a multidisciplinary team approach where different viewpoints are expressed. Proton beam therapy in adult and pediatric brain tumors, I think, is incredibly promising. It certainly has shown in some situations to improve outcomes in both adult and pediatric brain tumors. It does, however, require extensive infrastructure, maintenance costs, and specific expertise. So then we've got to bear this in mind: the contextual and geographical issues and the justification. What are our current availabilities and accesses? What are our limitations? If you look at the public hospital system at the moment, there are limitations that need to be addressed, and one needs to ask whether, if there's an allocated amount of money, is it best spent with a modality like this, or is it best spent optimizing the infrastructure we have before and then looking at a modality like this? And these are all discussion points and probably form the basis of why discussions like these were started in the first place. So thank you very much. I'm happy to take some questions.
Morocco, would you prefer that we do his Q&A so that we can relieve him? CEO, I think that would be best. Thank you. Oh yeah, from there. That's perfect. Any questions?
Thank you, Prof. In the interest of time and the fact that you out of the country. We'll take the Q&A for your section. Colleagues, any questions for Prof? All right. Looks like we could.
I'm Dr. Srinivas. Thank you, Professor Padachai, who you gave a very nice presentation, nice overview of your perspective on radiation oncology. I thought it was very interesting for hearing from a neurosurgeon. It's not a question as much as it's a comment. I appreciate the fact as you mentioned, it's a multidisciplinary team effort, especially pediatric neuro-oncology. Now with the new molecular classification kicking in, we are stratifying patients much better than what we have been doing so far. And we are, in many kids, we are trying to redefine the role of these treatments, the extent of the treatments, the aggressiveness of the treatment, the escalations, the de-escalations, and so on and so forth. I think kids are getting better and better in terms of their outcomes. Medulloblastomas, ependymomas, for example, we are routinely classifying them molecularly, the WNT, SHH, group 3, group 4. And we know if they are P53 mutated, then the surgeon is removed, but they have been referred to a tertiary center, a lot of big residual. We probably will not chase the disease in certain situations if it's a group 3 and it's a SHH P53. On the other hand, if it's a WNT and large residual, we'll just go and try to push in because we know the outcomes are going to be very good. In ependymomas as well, the ZAFTA fusions for supratentorial, for infratentorial, the PFA, PFBs, we are looking at 1Q gain and all that. So I think, your talk was very, very interesting in triggering that thought that it's a multidisciplinary team effort, and protons obviously will have to be a very, very small part of the entire gamut of the armamentarium we have against brain tumors, especially the pediatric brain tumors, which are, especially the PLGGs will also involve the medical oncologists, the pediatric oncologists as well these days, because chemotherapy is now considered standard of care for opticochiasmatic and many, I would say, diencephalic pediatric low-grade gliomas. Thank you so much for giving an excellent talk.
Prof, would you like to respond in closing? Thank you.
Thanks, Dr. Srinivas. I mean, those are all excellent points, and just for clarity, I'm in Cairo at the moment. It's a pediatric brain tumor symposium, and a lot of the discussion is revolved around exactly some of the points that you brought up now, the molecular classification, and it oftentimes it involves doing less. As neurosurgeons, we, for medulloblastomas or ependymomas, if you go back a few years where it was all histological, these tumors were, optimal safe resection was always the goal. But the point you made is incredibly relevant. With some tumors, you're looking at de-escalating. You would just do a biopsy for tissue diagnosis, and hopefully, just to take what you've been saying absolutely correctly, just one step further. But in the era potentially of radiogenomics, where we could identify these tumors better just on imaging, whether it's MR spectroscopy or nuclear imaging, we potentially will do even less surgically because we know the prognosis in these kids are like you said, in the specific type of medulloblastoma, if we know they're that poor, surgery then doesn't offer any or doesn't confer any additional benefit. And, it may be in those cases where things like proton beam therapy may or may not make a difference. So I take your point. I think that's a very valid thing. And that's probably where we're headed for certain types of pediatric brain tumors.
Thank you, Prof. Before we move to the next, our keynote speaker, we've got a view of cancer from a nuclear physician. I would like to introduce to you Professor Dibatso Bushumamni. He is a nuclear medicine physician, as I've indicated, a fellow of the College of Nuclear Physicians, at the Department of Nuclear Medicine at Steve Biko Academic Hospital at the University of Pretoria. He has demonstrated an ability of working in the private and private hospital and in health insurance, clinical research, medical education, data analysis, and strategic planning. He's an executive of the South African Clinical Sciences Society with a Bachelor of Medicine and Surgery from Wits, and also a Golden Key recipient. He's an adjudicator for medical technology in collaboration with the Innovation Hub in Pretoria. He's a winner of the Young Emerging Leader Award and highest rated research abstract at the 2018 World Federation in Nuclear Medicine and Biology, which was held in Australia in the city of Melbourne. Please welcome Professor Dibatso Bushumane for his presentation.
Thank you very much for that warm presentation. I actually see a couple of faces that I am aware of. The previous speaker, who was Professor Padeyachi, when I did my PhD at Steve Biko, I actually recruited patients from his department. And he was an excellent mentor to me. And I just wanted to say that I've actually moved from the University of Pretoria to now I'm located at the University of Limpopo, which is 270 kilometers north of Pretoria at Polokwane Hospital. I'm a nuclear physician by training. I'm the head of the clinical unit. I'm also a member of the provincial development planning team for the tertiary services. I'm in a strange position where I actually report to the CEO of the hospital and also report to the DDG of the province. And also the incumbent to be responsible for the tertiary grants that are going to be in Limpopo. There is going to be a new 477 bed hospital in Limpopo called Limpopo Central Hospital. So if any of you are interested in seeing the development of Limpopo, especially in Polokwane, I urge you to come and visit the department and visit the province. Colleagues, without sorry. Okay. Oh, the clicker is here. All right. Okay. It's actually quite interesting that we Dr. Ramiah, who is a radiation oncologist, was speaking, and for me as a nuclear physician, we deal with atoms. There is a joke that goes that you mustn't believe atoms because they make up everything. But let me just start by showing you what I'm going to discuss. I have basically chosen to talk about gliomas because that was my research topic, and it's something that I'm interested in. And I think most people in this room know what gliomas are, but have never actually experienced the dilemma of these patients. So you know that there are actually 4 main types of gliomas, and In actual fact, the most aggressive type is the glioblastoma multiforme, which the survival for it is actually quite poor. In South Africa, in terms of the incidence and also the prevalence of it, we see an equal distribution in males and also in females. As I've mentioned, that this Kaplan-Meier graph basically shows you the prognosis of gliomas, and if you follow line A, the ones that only had a biopsy, which was 25 patients, you can see that their overall survival was actually quite poor. You see actually a sharp drop off within the year of the biopsy. In terms of the predictive and prognostic factors, age still remains important. The cell lines, the extent of resection, which is what somebody like Professor Padeyachi was speaking basically does. And we also look at the type of mutations. I've introduced this slide today because mostly in nuclear medicine we use photons, and recently we actually use alpha particles to treat prostate cancer. But I think there is actually a significant role that neutrons and also other particles still play. I apologize, I can see that this slide does not project very well, but this is actually from the EORTC, which actually summarized the overall survival of the glioblastomas, and in all the studies that were done, the overall survival was actually poor. So in actual fact, in terms of the treatment for these primary brain tumors, the survival is actually poor. I'm not going to go into the pathophysiology of it because I'm not a pathophysiologist, I'm a nuclear physician, but we rely very much on the pathophysiologists to actually demonstrate to us some of the key features that we need to see in order to diagnose the gliomas, especially in adults. Now, in terms of the primary brain tumors, there are several of them, as you can see in the chart that I have put. However, there is a ongoing discussion regarding the reclassification of these tumors using the molecular tumor markers. Currently, in terms of the World Health Organization, they're still using the grading 1, 2, 3, and 4, which is the severe type. In terms of imaging, we still use the anatomical imaging, which is MRI. However, we can diagnose these tumors also using the PET scanners and also the SPECT scans, which is the single photon computed tomography. There is a role for PET scans in the diagnosis of gliomas. However, we have not yet identified the ideal tumor marker for the gliomas. What you're looking at here is transaxial cuts of the brain in which this patient had a glioma, and this was actually using SPECT scan. One of the issues that we were working with Professor Padayachi and the team at Steve Biko Academic Hospital was the concept of pseudo progression, because on MRI, it was actually difficult to tell after treatment if the tumor is progressing or is a pseudo progression. In terms of the treatment option, again, I see that I'm not quite sure if me and Dr. Ramiah used the same slide and article. I promise you we didn't talk about this. However, I do advocate for proton beam therapy as well. I can also say that in terms of some of the ones that are resectable, that we have seen that resection actually works. The current standard treatment of care is surgical. There's the adjuvant management, the chemotherapy using temozolomide and radiotherapy, and also the targeted therapy, which includes the proton beam therapy. In terms of the NCCN guidelines, you can see that in terms of the imaging of these tumors, MRI is still the gold standard, but what is advocated is that a multidisciplinary team actually gets involved when managing these pathology. The molecular targets that we're looking at, there are those that actually had a prognostic value and others that did not have a prognostic value. There are several articles that mention the use of tenascin C that was the frequently used target in the targeting of gliomas, but this study did not take much traction because we didn't have enough patients, as you could see. We had a study that also used NChem. Unfortunately, also we did not, this study did not progress to the point where we had enough patients in order to actually target a marker that can be used reliably. What is reliable and seems to actually is going to be used mostly in our context is substance P, which is conjugated with DOTA. I included this slide because in terms of the treatment of gliomas, there is this treatment where we can actually instill radiopharmaceuticals in the brain. However, as you can see that this is an extremely invasive technique. In terms of the radionuclides that are available, we have those that emit beta, gamma, and Auger electrons. However, even so, the prognosis, unfortunately, was not good when dealing with CNS tumors. In terms of the future prospects, we're looking at potentially using certain vaccines and viruses in order to actually transmit or deliver these radiopharmaceuticals for us. However, this is still very much experimental. There is actually a group that is targeting or looking at doing immunotherapy when treating gliomas. We're still waiting for their data. All that I wanted to say in this presentation is the role of the nuclear physician in actually imaging these diseases or these pathologies that are treated with proton beam therapy. And I also wanted to just make you aware that there are provinces in South Africa, especially in the Limpopo area, where there is pathology. However, we need significant support in terms of funding, and also please visit the province because in the next 7 years we'll have a novel hospital that we aim to have all the latest and efficacious modalities. Thank you very much for your attention. Did I wait for any questions?
Thank you so much. Thank you, Prof. It is time for me to introduce our final speaker for the day. So thank you for your patience today. Our next speaker is Dr. Srinivas Chilukuri. He's a key opinion leader in the field of radiation oncology in India. He's credited with pioneering Southeast Asia's first clinical program for particle beam therapy at Apollo Proton Cancer Center in Chennai in India, where he continues to lead pediatric bone, soft tissue, genitourinary and thoracic cancer radiation oncology program. Apart from delivering clinical service, he's currently running several prospective studies, including collaborative research with some of the finest institutions of the world. He also sits on several prestigious national and international panels, formulating guidance papers and advises governments and agencies such as the World Economic Forum. He is also the co-founding chairman. It's technology now. No, I'm getting there. I need to do a proper introduction. My apologies for that. He's a co-founding chairman of the Optimus Oncology, which is a healthcare startup providing modern and affordable cancer care in rural pockets of India. It has attracted funding of $5 million in the first 3 years of its operation and is currently serving 5 districts in rural Maharashtra in India. In 2009, he is also credited to initiate the first clinical program utilizing volumetric modulated arc therapy in the subcontinent and has been the clinical lead in the Advanced Radiotherapy School. Through this school, which was run in collaboration with various medical systems, he has trained more than 200 radiation oncologists and medical physicists belonging to Asia and Africa for over more than 7 years. He has also been a teacher and has trained several postgraduate students in radiation oncology under his mentorship. Dr. Chilukuri was trained from some of the finest institutions, such as the Armed Forces Medical College and Tata Memorial Hospital, and has had exposure to some of the best institutions of the world, including the Miami Cancer Institute, the Mayo Clinic, through short clinical training programs and fellowships. He has been awarded fellowships by American Society of Oncology and European Society of Medical Oncology for being one of the most promising oncologists. He has won several national and international awards and has several international scientific publications to his credit, including in high impact journals. He believes in lasting bonds, in building lasting bonds with his patients, and in the magic technology in making lives better. He is passionate about leveraging technology towards equitable cancer care and building sustainable healthcare models across geography. Without further ado, Dr. Srinivas Chilukuri.
Good evening. Pardon me, I'm doing this for the 4th time in 3 days. So I'll try to be brief because I think it's already a bit late. And it's my pleasure to be here today, to be talking to you and sharing my experience on proton beam therapy from our country. I bring warm regards to you from our center, Apollo Proton Cancer Center in Chennai, which is located in southern part of India. India is a big country, but it's located in the southern part of India. It's on the eastern coast of India. And it's not too long, clearly 14 hours journey. Tomorrow I'm going to make the journey. Tomorrow morning I'm flying back to Chennai. I'm eagerly looking forward to going back home, no doubt, but I really enjoyed my stay here in South Africa and interacting with my colleagues, especially in Johannesburg. I really like, a very warm welcome I received at Johannesburg. I'm sure all of you have heard and seen all the rich cultural and diversity India offers, including food, the attires, the Bollywood, the dance, the nature, etc. And I welcome all of you to our country to see its beauty and, of course, to visit our center as well. Looking at the cancer incidence in South Africa and India, India's population is approximately 23 times more than South Africa, and the number of new cases is about 12 times. The new cancer cases, 100,000. We see about 1.3 million cancer patients in the country every year. The number of deaths are about 56,000 and 12 times 851,000 cancer-related deaths each year in India. So India and South Africa share a common economic kind of or probably in human development index. India and South Africa probably stand at the similar stage, and we are going to see a large jump in cancer numbers, irrespective of our current status. We are going to see a huge jump in numbers, and we need to be geared up for that, clearly. And there are multiple ways to gear up with it. I'm not going to go into details about how we're going to gear up, but there are many advances in the field of oncology which have taken place in the last 10, 15, 20 years, which clearly appear very promising. The one in genomics, robotic surgeries, high precision radiation therapy, big data machine learning, artificial intelligence paradigm, which is helping us to make the treatments more personalized compared to what we have been doing so far. And there are many in pipeline, and radiomics. I think one of the previous speakers mentioned about radiomics and radiogenomics driven interventions, which are going to, where we probably are going to escalate or de-escalate treatments based on all these parameters. CAR T-cell therapies. Apollo has initiated CAR T-cell therapy as a routine service, of course, in a clinical trial right now, phase 1 clinical trial, but CAR T-cell therapy is also being delivered at our hospital. There is something called flash therapy, very exciting, innovation in the field of radiation oncology. I don't know if it succeeds, it will completely change how we practice radiation therapy in, and hopefully that will, change how we give radiation therapy in the future. And of course, there's work on personalized cancer vaccine, CRISPR, gene editing, etc. So some exciting developments in pipeline. As a radiation oncologist, depending on where you are, whether in your low-income country or low and middle-income country or high-income country, the radiotherapy utilization is somewhere between 55 to 65% of cancer patients require radiation. And the aim of radiation is to improve the tumor control probability while reducing the normal tissue complication probability. And we want this to widen so that at that point, at any point of time, we achieve a very high rate of success, but without giving much toxicity. So we want this to be as wide as possible. And there are many innovations in radiation therapy. For non-radiation oncologists here in the audience, you can see that there is a horseshoe-shaped white thing, which is, is like a tumor. The normal tissue is in the middle and very intertwined with the tumor, which typically happens. And in fact, we don't even get this gap always, but essentially in two-dimensional radiation therapy, we are irradiating uniformly both the tumor as well as normal tissues equally without differentiating them. But in 3D conformal radiation therapy and IMRT, what we are trying to achieve is to give differential doses to the tumor and spare the normal structures as much as possible. You can see that the normal structure is receiving lesser doses of radiation compared to the tumor. And similarly, in IMRT, we are getting better and better with VMAT and helical tomotherapy and CyberKnife. All these, we are trying to make treatments more and more conformal while we spare the normal tissues to the best extent possible. So Dr. Ramiah already mentioned about the proton beams and the BRAC peak, and which is what the strength of a proton is essentially. Because there is no dose beyond the BRAC peak, there is very limited dose, no exit dose, literally, and you could smartly make use of few beams, not multiple beams. In VMAT, essentially, although we don't call it as beams, in VMAT, we give radiation in the form of arcs, right? In volumetric modulated arc therapy, it is like an arc treatment. But with protons, we can actually limit the number of beams in a smart way to make sure that the integral dose or the low dose is significantly reduced with protons because there is no exit dose. If there is no exit dose, potentially the toxicity is less. You could increase the doses to the tumor and probably even make the tumor control even better, reduce the incidence of second malignancies, and hopefully improve the quality of life. So these BRAC peaks are being deposited in a pencil beam scanning proton therapy. What Dr. Ramiah showed is the scattering beam and the scanning beam. Scanning beam is a new therapy, new technology. I always say this, there is a proton and there is a proton. And almost 50 or 60% of proton installations across the world are older generation proton therapy techniques. What we have currently in Chennai and in some of the new contemporary centers are the more modern units. 60% of centers do not have image guidance. That means we can't really see where we are hitting the tumor. But the recent ones all have image guidance. Just for the sake of radiation oncologist audience, I also want to say that we all have respiratory gating, surface guidance, you name it, all the bells and whistles, what we see on a linear accelerator are now seen on proton therapy. So that is a real sea change in how we deliver protons. And that is why we are seeing better and better outcomes. And I hope that some of the randomized trials and all the evidence we are collecting for proton therapy should involve all these on these techniques, because otherwise we are comparing apples and oranges, which is not appropriate. So these are the BRAC peaks which we are trying to deposit in the tumor, spot by spot, layer by layer, from the most deepest layer to the superficial layer. And that is what, this video clearly shows, that, you can see that the Bragg peaks are being deposited in the tumor, and there is absolutely no dose around the tumor region. So essentially, protons stop, photons don't stop. Of course, it doesn't look like this. We always use multiple beams to make sure that the dose is the high doses are restricted to only the tumor region. This is a VMAT treatment plan for a sacral chordoma. And you can see that I'm unable to spare the rectum. The bladder is also receiving significant amount of doses. It may not be very high doses, but it is still receiving 40 and 45, 50 gray. Patient will have some cystitis, which is inflammation of the urinary bladder. He will have some proctitis, which is the inflammation of the rectum. So they are likely to be some symptoms, especially if it is a chordoma, where I have to treat something like 74, 75, or 76 gray, which is quite a high doses. And these normal structures are going to be radiated to their, to the limits where, we are going to see some toxicities in these patients. This is a tomotherapy plan, very similar looking. The low and intermediate doses go well beyond the tumor, but this is a proton plan. You can see the difference in terms of, because protons stop, you can see that the half of the rectum is not receiving any dose. The urinary bladder is not receiving any dose. The pelvic marrow and the femoral heads are not receiving any dose. So if this patient, if it's a Ewing sarcoma, very similar location, say sacral Ewing's, the patient would have received a ton of chemotherapy. Bone marrow is already suppressed. And if I'm giving protons, you would see far less bone marrow suppression compared to dose bath to the pelvic marrow. Now that we have more evidence that dose escalation in proton therapy for Ewing sarcoma cancers. So similarly, in children or even in adults or adolescents who receive craniospinal radiation, there seems to be a large benefit. One of the best techniques you could use is helical tomotherapy, and compared to that, there is a significant difference. Similarly, mediastinal tumor, the amount of lung and heart we can spare. Prostate, I will show a few slides on and prostate and brain tumors as well. There is a significant sparing as shown by the previous speakers as well. So potentially there's a lot to gain in pediatric cancers, in thoracic, in prostate, in sarcoma, head and neck, brain tumors, and GI. So it looks like a better treatment, and not just physical dose, but the radiobiological effectiveness. Dr. Ramiah mentioned that the LET is very similar to X-rays, but the LET varies across the Bragg peak between 1.1, sometimes 1.15, 1.35, and 1.7 at the distal fall off region. And you can see that RBE varies clearly. And the reason why RBE varies is that the complexity of the DNA damage is much more with protons compared to X-rays, and therefore we could see that RBE is higher, which is radiobiological effectiveness. That means compared to X-rays, they are 10 to 70% more effective in terms of tumor control, potentially. Are we able to use that completely? Not yet, but we can potentially use it in the treatment planning. So if it is biologically better, physically better, then why aren't we using this technique for every patient? It's not possible because it's a huge infrastructure. 3-floor gantry, 130-ton gantry, huge infrastructure, the cost of equipment, maintenance, number of engineers required to maintain it 24/7. The cyclotron is 12 feet in diameter. It's a huge thing to maintain and to run. And therefore, it is extremely challenging to have these centers in multiple centers across countries. And therefore, we have limited number of centers in Asia, limited number of centers in North America and Europe, and maybe even in Far East, in Japan and Korea as well. But you can see that, if you're standing here, it's a huge thing. And literally, I always say this to just tell you how, build it and then bring in the machines. It's not possible. You have to bring in the machines and then make a building around it. So that kind of huge equipment. Electricity cost itself is like every month, I don't know how much, I would say a few $100,000 electricity costs. The maintenance costs, you could buy a high-end LINAC every year, a true beam every year, right? So that is how maintenance cost of this kind of equipment is. This is almost 200-meter long beam transportation system. And it goes through 64 dipole and quadrupole magnets, the proton beams, because we need to select energies. Tumors are treated with differential energies. So they are treated from 70 million electron volts to 226 million electron volts. So we need to select energies for each layer. So all these is energy selection system and beam transportation system before the actual proton beams enter the human body. So protons have to be accelerated to very high speed. And for that, we need cyclotron. So cyclotron is a place where protons are generated. Then they travel all these to jump through hoops, literally, and then finally enter the room, and then they are delivered precisely. And despite you seeing a huge infrastructure, 130 ton gantries, the precision is as good as a compact linear accelerator. So that is where we have come so far. I mean, the journey in proton therapy, kind of the technological evolution has now taken place to a level where we have come to that sub-millimeter accuracy level. There's also a lot of inherent differences between each proton center. For example, the spot, which I said, the Bragg peak width was 15 millimeters to begin with, 23 millimeters. Actually, the first initial centers were 23 millimeter. That means the Bragg peak width was 2.3 centimeters. Now the Bragg peak width is 3 millimeters. The highest energy Bragg peak is at that. So there are many differences in terms of technology in proton therapy, and very few actually know it and understand it, and therefore that all needs to be considered when you review the literature on proton therapy. It took us almost 6 years from actually the day we signed the contract with the vendor who supplied us the machine from Belgium. It took 6 years for us to beam on and treat the first patient. The first patient was actually, in fact, we treated 2 patients. The first patient was a child who had craniopharyngioma, and another, we thought we'll start with a simple prostate. So we had a high-risk prostate cancer from Australia, a guy in Indian origin, but from Australia. He came as the first patient. So we treated in January of 2019. So we are 4 years and plus. So based on all these, I told you that it's not easy to set up a proton therapy machine, although there are some advantages. Dr. Ramiah mentioned regarding, very elegantly, that we need to really be, responsible in recommending proton therapy for the right reasons. And the American Society of Radiation Oncology gives some kind of a guidance for radiation oncologists in US, and we could use that as well in a way to start to begin with. And as Dr. Ramiah mentioned, showed some indications, they are very, very similar here. The ocular tumors, the chordomas, chondrosarcomas, spinal tumors. So spinal could be, again, could be E-wings, could be osteosarcomas, could be any bone tumors, spinal tumors, hepatocellular cancers, primary or benign solid tumors in children treated with curative intent or even occasionally palliative intent also could be treated with protons. And that is what Astro says. Not just that, but patients with genetic syndromes where we expect higher bit of side effects with radiation, such as NF1, retinoblastomas, where we try to avoid radiation as much as possible. But yet, if we have to treat them, say Lee from any syndrome has a brain tumor, no, we have resected, but after that, what? We have to radiate. So although I would not like to irradiate those patients, but if they have to be irradiated, better done on protons compared to X-rays. Malignant and benign CNS tumors, advanced unresectable head and neck cancers, cancers of the paranasal sinuses and other accessory sinuses, non-metastatic retroperitoneal sarcomas, re-irradiation. Again, another key important indication. In fact, I think 35% of patients we have treated at Proton Center so far have been re-radiation. Again, a challenging scenario for radiation oncologists. Nobody likes to be in that situation where we tell our patients that there is a higher probability of toxicities, and we sometimes are unable to give high doses, especially in head and neck region, where the mucosa is a dose-limiting structure. So re-radiation is an important indication for protons as well. But there are group 2 indications where the evidence is emerging. There are randomized trials. There are phase 2 prospective studies where the evidence is being collected. We are understanding. Our understanding is getting better and better, but still they are not standard. Proton therapy is not standard in these indications, such as non-T4 and resectable head and neck cancers, thoracic malignancies, abdominal malignancies, pelvic malignancies, non-metastatic prostate cancers and breast cancers, where data is being collected. So there are ongoing randomized trials now. This is a paper from Justin Beckelman from UPenn, where he kind of summarizes the randomized trials. The breast cancer randomized trial, glioblastoma, lung cancer, prostate cancer, esophageal cancers, liver tumor, liver cancers, hepatocellular, low-grade gliomas, and head and neck cancer. So these are some of the randomized trials which are ongoing right now, and hopefully in the next few years we will have some answers in terms of in these common cancers, who are the group of patients who could benefit from this. So we recognize that there needs to be more evidence for protons. And as a proton therapy center, our mandate is also to generate evidence, not just to provide clinical service, but also to generate evidence in Indian context. So Indian cancers. There is a trial for prostate cancer, for example, in United States, and they are doing for low and intermediate risk, only proton only for prostate only disease. I don't think there is going to be a big difference between proton versus photon and prostate only cancers. But if you have a high risk cancers, which is Indian, because we don't do screening for prostate cancers, we do see high risk prostate cancers. In high risk prostate cancer, where we need to treat nodes or node positive prostate cancers, is there a benefit? That is a question which we need to answer. In oral cavity cancers, these are not cancers which are commonly seen in United States or in Europe, because we are probably considered the capital of oral cavity cancers in the world, because a lot of Indians chew tobacco. And oral cavity is, the tongue, the floor of mouth, the palate, buccal mucosa are extremely common. Alveolus. So if these are a set of tumors, we need to generate our own evidences, not rely on the West or for North America or Europe to give us answers in maybe 20 years or 30 years from now. Meanwhile, this is an Indian problem, and we need to solve it in an Indian way. So we have written this and we published this in Radiation Oncology a few years back. We said that there is a need for professional organizations like ASTRO, ASCO, maybe even SAMA, and even South African Radiation Oncology associations, innovative trial designs. What Dr. Ramiah showed is not a randomized trial design, but actually some kind of a model-based selection, which is pioneered by the Dr. Langenbeek's group in Netherlands. Collaborative approach for evidence generation proton beam therapy. So there are now multiple sites where there could be benefit, but overall percentages ranges somewhere between 15 to 25%. Now, indications at APCC so far, we've treated about 900 plus patients. 45 patients are already on the couch right now, being treated on a daily basis. 25 plus 25. You can see the pediatrics is 25%, 25%, almost 26% is brain tumors. So these are the most common set of indications at our hospital. We also treat a large head and neck and skull base, where there is again no controversy. Head and neck skull base chordomas, chondrosarcomas, spinal chordomas, chondrosarcomas, even paranasal sinus tumors, difficult skull base, salivary gland tumors with perineural extension going up to the brainstem. These are extremely nightmarish cases for radiation oncologists to handle. If I want to give 70-72 gray for a salivary gland tumor, not very radiosensitive, those are the ones which really benefit from proton beam therapy. So head and neck and skull base, and the bone and soft tissue, again, bone and soft tissue are Ewings, osteos, chordomas, chondrosarcomas, not just in skull base, but also in the spine, in the pelvis, in the difficult locations, in the chest wall. These are again indications for proton. So 90% of patients are actually these 4 indications: neuro, peds, head, neck, skull base, and musculoskeletal bone and soft tissue. And others are all small amount of prostates, small breasts, very few thoracic, extremely selective ones for the rest of the indications where there is no robust evidence for protons. Pediatrics, I treat pediatrics, and it's my pleasure to treat pediatrics. I love treating children. The fact that the outcomes are far better in children compared to adults, and we do with a lot of love and care. Of course, there are child's play areas, there are child-friendly zones. We make colorful masks to engage with the children. We also have a kind of a video to show how the children have to go through the proton treatments. There's a storybook for someone to read it in all vernacular languages in India, because India has almost 30 official languages. So we have translations of these proton stories as well. I showed this in the afternoon as well. This is a child of medulloblastoma who was treated several years back with radiation therapy, surgery, radiation therapy, and chemotherapy. There are multiple late effects the child is seeing right now. She's disease-free. She's completely disease-free after 10 years, but she's unable to walk. She's unable to go to school. Her growth is stunted. She has multiple hormonal issues, endocrinopathies, skin changes, hair changes, frequent infections. She's obese. She has a sister, we compare her to. She really has some psychological issues because sister is able to do all these and she's unable to. And clearly, we are doing better as far as the survival is concerned, but survivorship, we need to do even more and more better. And this is not an isolated event. This has been shown in St. Jude's Life study that there is a considerable amount of burden of late effects childhood cancer survivors see after they are 30, 40, 50 years in terms of reproductive, in terms of multiple problems, second cancers, cardiovascular, renal, hematological, ocular, lung issues, endocrine issues, musculoskeletal issues, neurological, etc., etc. So there are multiple issues in childhood cancer survivors, and we all need to pay attention to how to reduce it. Therefore, we are trying to escalate or de-escalate treatments based on certain molecular factors. Why is it really beneficial? Because the benefits of proton therapy in pediatrics are seen because almost all late effects are dose dependent. We give higher doses, there are higher chances of late effects. And late effects do not appear in organs that are not irradiated. You can see that if you're not irradiating heart and lungs and kidney and even the bone, you're not going to see any late effects there. Similarly, in a perineal rhabdomyosarcoma, if I'm not giving any radiation to the labia of the child, of vagina, I can say that the child may have normal sexual function in the future. And you can see that protons is beautifully sparing all these external genitalia compared to conventional radiation. There is an impact of low and intermediate doses. You would say, okay, the tolerance is met, but there is a low dose to the uterus. Do we know the tolerance doses to the uterus? I'm not sure, but there is some data that, if you give some threshold doses, the uterine function, the ability to bear children may not be adequate. So If you give higher doses, you could have a child who could be infertile potentially. So you could spare these things with protons. You could spare the dose to ovaries, dose to uterus and vagina. Ovaries, you can even transpose them. You can actually move them outside the pelvis, but you can't move uterus or vagina. They are relatively fixed. Similarly, the vasculopathies. There are, this is a cellular tumor which was treated with, this is proton plan. There is something called vasculopathy, higher risk of cardiovascular events. There is now actually a prospective study at St. Jude's led by Dr. Tom Merchant, where the primary endpoint is actually the incidence of vasculopathy between proton versus photon. So, which is interesting study. So there are theoretical reasons why protons could be beneficial in these children, but is it really? That is going to be answered with this randomized trial, this prospective trial. So summary of benefits in children are reduction in neurocognitive decline. We could spare the hippocampus, we could spare the medial temporal lobes where they are all associated with memory and higher intelligence. You could spare that better with protons in several situations. Better endocrine preservation, lesser organ dysfunction, preservation of fertility, sparing of gonads, and lesser probability of second cancers. In fact, we have a lot of publications in all of these, and especially we are very proud to showcase this in Neuro-Oncology, which is published in 2020, quality of life in young children less than 4 years, brain tumor survivors treated with proton beam therapy. And this is a consensus paper, and they've called like 30 top pediatric oncologists of the world, and they were put in the room and asked, for low-grade glioma, optic pathway glioma, and all these tumors, what would you prefer? Would you prefer proton or would you prefer X-ray-based radiation therapy? And most of them, for most indications, have there was a consensus that proton would be significantly better in these children with pediatric tumors. So this is proton therapy usage trends in pediatric cancers in the United States. As far as the clinical trials are concerned, the prospective studies, they were just 8 in 2002, 69 in 2012, and 167 in 2022. So there is a significant jump in the prospective studies for children. You can also see that in United States, 54% of RMSs, rhabdomyosarcomas, 50% of medulloblastomas, 68% of ependymomas, 53% of Ewing sarcomas, 30% of neuroblastomas, and all these ATRT 62%, nasopharyngeal carcinomas 46% are being treated with protons. This is data from high-income country. We may not reach there very soon, but we will have to aim to reach there sometime, that at least a good chunk of our medulloblastoma kids, a good chunk of ependymoma kids, good chunk of rhabdomyosarcoma kids need to be treated, or Ewing sarcoma kids need to be treated with protons eventually to improve our late effects. We have published this early experience of treating children. We treated about 50 children initially, and then we published. And this was a group of patients whom we treated, about 47 of them, less than 25. So a mix of both intracranial and extracranial tumors, pediatric gliomas, germ cell tumors, medullos and Ewing's, medullos, ependymomas and cranios among intracranial, clival chordomas for skull base, rhabdomyosarcoma and Ewing's, and pediatric nasopharynx. We've also published our outcomes on image-guided pencil beam scanning for craniospinal radiation. This was published in Radiation Oncology. Treated 40 patients, and we presented our clinical outcomes. This is published in Clinical Oncology, which is an official journal of Royal College of Radiologists in the United Kingdom. What we did was we've treated now a significant chunk of CSIs, and we thought we will critically do a critical appraisal of pediatric embryonal cancers treated with image-guided intensity modulated proton therapy, and see how our contours are, how our dosimetric outcomes are, how our clinical outcomes are. So we did a kind of an audit on all of these patients, and we have published this recently in 2022. This is not yet published, I think, in print. It's an article in press. We are looking at starting this very, very soon. In in APCC, Pediatric Radiation Oncology Registry, essentially it is undergoing the IRB approvals right now. Once it is approved, it will be available in public domain. This all children, irrespective whether being treated in proton or photons, they are being part of this PEDRO registry, where the primary outcome measure is going to be evaluation of health-related quality of life through an instrument called HR-PETSQL version 4.0. And of course, the secondary outcomes are early late toxicities, disease-free survival, local control, and overall survival. So essentially, this registry is going to run for a few years before we have results. Similarly, I think the neurosurgeon presented very elegantly a lot of indications of proton, including Dr. Ramiah. There are now pediatric and adult tumors which we are treating routinely. As I said, 1/4 of our all proton patients are CNS, including, in fact, if you can count the pediatric intracranial tumors, they are actually very, very a big number. But this is a very rare situation, acute promyelocytic leukemia, AML M3, who had an isolated CNS relapse. We treated him with craniospinal radiation. You can see that the patient, when he came, he was on a stretcher, literally. He was treated and he literally walked out of the hospital. So had a very dramatic response and is doing well so far. We have treated a good number of ependymomas as well, both in the primary setting as well as the recurrent setting. The outcomes are actually very good. Ependymomas, I showed you that in US, the 2021, I think about more than 65% of children who are diagnosed with ependymomas are being treated in US with proton beam therapy. I think ideally this is a gold standard indication for proton beam therapy. Similarly, intracranial germ cell tumors for these children or even adolescents, they require large field irradiations, either CSI or whole ventricular irradiation. And these are situations where I would say protons would score over conventional radiation therapy. Similarly, difficult location PLGGs, I think Dr. Ramiah showed a very elegant plan comparison. I agree with whatever decision has been taken by the parents. I would tell the same. But this is not a child, it's actually an adult, was actually treated with protons. But what we saw we were in awe of proton after that was that there was disappearance of tumor. Normally, we don't see disappearance of tumor. We see stable disease, we see some shrinkage. I don't know, for some reason, this was also H3K27 not mutant. It did not have any IDH mutation. It was actually BRAF fusion was positive in this patient. So it was pilocytic low-grade gliomas. The Ki67 was 1 to 2%, just similar to your case, except for the NTRK fusion. He had BRAF fusion. And the gentleman is on has a beautiful advertorial. If anyone is interested, I would like to show you that his motor power recovered and his MRI is actually showing complete response, which we are unable to explain why this has happened. Is it because of a different biology of the tumor, or is it because of the protons? I'm not sure. IMPT for molecularly favorable low-grade gliomas. Now there is a randomized trial, which is an NRG, is recruiting a trial, phase 2 randomized between proton versus photon for IDH mutated low-grade gliomas. And again, we have to say that in protons, we are seeing disease actually disappearing rather than actually typical shrinkage we see gradually over a period of time. So there seems to be a difference, a biological effect, which we really cannot explain right now. But I'm sure this trial also will show that radiological responses are definitely better with protons. Similarly, glioblastomas, probably the most challenging tumors. We don't advocate protons routinely, but there are certain individuals who could benefit: recurrent glioblastomas, epithelioid glioblastomas, MGMT methylated glioblastomas, one could consider protons as part of a clinical trial. NRG is actually randomizing patients in a phase 2 trial. A large chunk of musculoskeletal tumors are also being treated. Out of them, chordomas and chondrosarcomas constitute the major chunk, but Ewing's, osteos, soft tissue sarcomas, and plasmacytomas also have been featured in this list. Again, as I showed you for pediatrics, we are trying to treat all the sarcomas in a prospective registry, because it's a responsibility to tell our colleagues that these are the outcomes, these are our outcomes, and because we are making sure that IRB is keeping a watch on us so that we behave responsibly, we publish outcomes honestly, there is no physician bias involved in it as much as possible. So that is why we are maintaining this prospective registries. So this is one of our early patients. You can see huge sized sacral chordoma treated with protons in February of 2019. August 2019, you can see the shrinkage of tumor starting the beginning. And later on, you can see that the tumor has actually become completely hypoperfused and the tumor started shrinking. You can see beautifully that the size is now significantly smaller compared to the previous size. Similarly, this is a pelvic osteosarcoma. You can see, we treated this patient after chemotherapy, and of course, was given proton beam therapy. And after protons, you can see this is pre-protons. This is December 2020 after 6 months, and this is after almost a year. And you can see that the patient remains stable and continues to remain in remission. In an aggressive osteogenic sarcoma, I think there is now evidence, of course, from retrospective data that the outcomes are much better with proton beam therapy. Thoracic cancers, again, not a standard indication, but there are certain patients who would really benefit. This is one of our patients, 63-year-old gentleman, quite obese, 120 kgs, had squamous cell carcinoma of left lung, T3, N3, M0, diabetic, hypertensive. Similar to what Dr. Ramiah showed, what happened in this case is there was a radiation oncologist in Mumbai who actually planned him on IMRT and saw that the doses to lungs and heart was significantly higher. The mean heart dose was 30 gray and the lung dose volume receiving 20 gray was 36%. Very high, so not suitable for concurrent chemoradiation. So he referred to us and say, okay, Srinivas, why don't you plan on protons and send me the plan and I'll discuss this with the patient and let's see what happens. And we saw that heart dose came down from 30 gray to 7 gray. The mean dose came down to 20 gray to 12 gray, V20 36 to 22%, V5 60, more than 60%, which we try to keep it less than 60, but 35.5%. So voila, we saw that there was a great benefit with protons in lung cancers. It's not a standard indication, but there's no need for randomized trial to tell us that here is the benefit in this particular patient, and this patient benefited with that comparative plan, and therefore we treated him with protons. And he's become one of our biggest patient advocates for proton therapy because he recently had made a big announcement, did a big press release for us because he wanted to, to spread the awareness of proton therapy in lung cancers. He also ended up receiving 1 year of immunotherapy. So I'm not taking all the credit that proton therapy cured him so far, control, but there is a lot of treatments, chemo, radiation, followed by immunotherapy, but proton therapy at least could give him a very good quality of life and definitely potential long-term control of disease. There is a randomized trial in esophageal cancer. It's a phase 2 randomized trial published in Journal of Clinical Oncology. It actually showed that the total toxicity burden in esophageal cancer was significantly lesser in patients treated with protons. So there is some kind of an evidence from phase 2 randomized trial. This trial is published in Journal of Clinical Oncology. This trial comes from MD Anderson The first author is Stephen Lin. It was published in JCO in 2019. So there is evidence, very good evidence for esophageal cancers as well. Prostate, I have put prostate because I saw that prostate is #1 cancer among men in South Africa. So I thought I'll put a few slides. All patients of prostate cancer who are being treated at our center on protons are part of a registry study called ProCube. It's kind of a basket trial where we are including definitive patients, post-operative patients, oligometastatic patients. We are giving 5 fractions as well, 36.25 to 40 cobalt gray equivalents in 25 fractions. The primary endpoint is actually PR25 based patient-reported outcomes. And of course, the secondary endpoints are REST, physician-reported toxicities, disease-related outcomes, PSA kinetics, etc. So if you see, I mean, it looks better. There are no major advantages because there's no major structure in low risk, high risk prostate cancer. When you're treating pelvic lymph nodes, there seems to be significant benefit in terms of reducing not just the bowel dose, the bone marrow dose, but the bladder dose as well. And what we did was, this was published by me and my team, and we basically compared IMPT and IMRT for high-risk prostate cancers who needed pelvic nodal radiation. Of course, there was a significant dose benefit both for bladder and replication probabilities, and based on that, we saw that there was a 17% reduction in the GI toxicity, grade 2 toxicities, and about 12% reduction in the genitourinary toxicities in these 6 domains: the fecal incontinence, the bleeding and stool frequency, and the GI side effects, and hematuria, dysuria, urinary incontinence for GU side effects. So we do feel that in high-risk prostate cancers, there is a benefit with protons. Especially if you're unable to give brachy, I think you can escalate the doses quite safely with protons. Also, we do see once in a while patients with poor IPSS scores, where their baseline urinary function is very, very poor or not so good, where IPSS scores range between 15 to 25. And I think there seems to be some benefit with protons, and that is what our experience tells us. We want to publish this very soon in our own experience. We also, there is a data that the long-term outcomes following proton therapy for young men, less than 65, are able to preserve their erectile function, 72 and 67% at 2 and 5 years. This also, based on indirect comparison, seems to be slightly better than conventional radiation. Although by and large, more than 50% of patients receiving radiation therapy, external radiation therapy, do preserve erectile function, but proton therapy seems to be slightly better as far as indirect comparison goes. So NCCN guidelines now mentions proton therapy as part of their guidelines. And therefore, I would say that and role of proton therapy for prostate cancer is in situations where we expect high toxicity or situations where we are treating high risk prostate cancers. Protons could be beneficial in younger patients, multiple comorbidities, variant anatomies, poor baseline IPSS scores, high and very high risk cancers, GG5, GG4 cancers, escalation. Head and neck is also one of the key indications. As I mentioned, oral cavity is our primary research focus. My colleague, Dr. Sapnangia, looks after this site, and she's very passionate about oral cavity cancers, proton therapy, and how it can improve quality of life and reduce the mucositis. But I think these are clear-cut indications: skull base and PNS cancers, salivary gland tumors, and re-radiations. These are challenging tumors. I think we strongly believe that these cancers, proton offers a better chance of tumor control. So it's probably, I would say, worth the cost of protons in many situations. This is a meta-analysis for paranasal sinus, which actually showed overall survival advantage with proton beam therapy. You can see that, the 5-year overall survival was almost just about significant, and disease-free survival is local region control, and overall survival is actually better in patients receiving charged particle therapy. GI cancers is also is an exciting upcoming emerging indication, especially in hepatocellular cancers. There's a lot of data from Japan and Korea for hepatocellular cancers, those Child-Pugh B and C, A6 ones and above, where surgery is not feasible, transplant is not an option, or bridge to transplant radiation. We saw that there could be benefit with protons, especially in cirrhotic liver, where we want to reduce the exposure of normal liver to radiation. One could potentially think of protons. Of course, there are now good options like TARE and TACE and RFAs and etc. But for large tumors, cirrhotic, I think proton offers a very good option, especially those with PVT, that means portal vein thrombus. I think there is a distinct advantage. We also have treated few pancreatic cancers, locally advanced with chemoradiation. I think the doses to small bowel significantly lesser. The tolerance to treatment is extremely good. So another last few slides of mine, of course, the cost, I think Dr. Ramiah mentioned very, very elegantly. We have argued the same in this paper. It was published in Journal of Clinical Oncology, Global Oncology. Is the need justified? It's a difficult question. It is yes and no answer, but essentially there needs to be more collaboration. Clearly, in those countries which cannot really cannot justify proton therapy, I think there's a need to collaborate with those who already are adopted this technology. So I think it's a good note to end my talk based on this. There could be collaboration between South Africa and India, because South Africa doesn't yet have a proton facility. And we have argued that access versus timely adoption of modern technology cannot work. They cannot compete with each other. You cannot really say that unless all the cobalts are replaced with linacs, I will not treat stereotactic treatments, or I would not do robotic surgeries. It cannot happen that way, because robotic surgeries have to happen. Proton therapy also has to come. And we need to replace linacs, and we need to do other things, fix our healthcare, and et cetera, et cetera. So these have to be parallel goals and not mutually exclusive goals. So to conclude my talk, we've treated more than 900 patients so far. Preliminary experience is promising. We are collecting data prospectively and for multiple sites. So far, the rates of acute toxicities are low. There are a large percentage of recurrent and re-radiation patients so far. As the footprint of the machine comes down, the cost is also likely to come down. Several RCTs are going on right now. Hopefully that will answer and refine the indications in the future. Thank you so much.
Can the speakers who presented to just come in and sit here so that we have a panel of questions, and then the CEO of SAMA, Dr. Basil Enicker, will be doing the Q&A as well as the closing.
Good evening once again, colleagues. Thank you for staying with us. Before we start, maybe can you just please give us presenters another round of applause? I think they are available to take any questions that you might have. One of the observations and that one had is that possibly, I think the last slide is the most important one that Dr. Chilukuri was talking about. There is role, but then there are barriers, to us getting that. And I think it will be one of the, things that we would want to interrogate in this, session. But importantly, I think, quite a detailed discussion around the clinical, significance of this treatment modality in the country. And probably we really don't need to be doing, the same kinds of things already. We can learn from what Apollo in India has done. And, the main thing is that we've got similar, kinds of demographics, similar kinds of health challenges. So maybe that's exactly what we need to be interrogating as we take this discussion forward. So let me open it up then for questions.
Any questions?
Thank you very much for. Hello. Yes. Thank you very much for those excellent presentations. But for Prof, you mentioned that this is a very expensive piece of equipment, and the prospects of us having it in South Africa at the moment are not that great. And you mentioned in your slide that patients should have access to it at low cost. Would you mind expanding a little bit on that from the South African context?
Well, yes, all countries cannot justify proton therapy installation right now, which is a fact, because based on our requirements, needs, the incidence of cancer, the incidence of cancers which could benefit with protons, with the amount of evidence we have so far, is something which I don't see that many countries will have proton therapy facilities. But that gives an opportunity for countries like South Africa, where there is not yet a proton therapy facility, to partner, to collaborate with those who already have and adopted this technology. Yes, the cost is a barrier, access is a barrier, and we can work to kind of address these barriers, address these challenges in a constructive way. We are now able to treat children from India, and even we have treated a few children from Mauritius, for example. I would give an example of Mauritius. 2 children from Mauritius were treated at significantly lower cost through help from a non-governmental agency, NGO, working in Chennai, actually fully funded 2 children with proton beam therapy. So I think where there is a will, there is a way. So if we strongly feel that a patient could benefit, costs are not really the biggest barriers. One could look at addressing them in a large way. May not be possible in all situations, but it is possible in most situations. And having said that, I know that South Africa doesn't have it yet, but I hope South Africa has it very soon, and maybe in the next 5 or 10 years. The reason being, South Africa is a leader in medical field in the entire continent of Africa. And I feel there are excellent clinicians. Of course, the infrastructure is very, very similar to in India, that there are centers where there are top class facilities, but there are other centers where there are not enough facilities and there are resource constraints. So there has to be, both high-end technologies and while we are working for access and better access to basic healthcare. So I think these are my comments. Of course, Dr. Ramiah will have his own thoughts.
Thank you very much. Yeah. So, obviously as a radiation oncologist, it would really be nice to have access to a proton center in South Africa. But the reality is that they are expensive to develop. I mean, if we're looking at a proton center, probably close to R1 billion to develop a proton center in South Africa. If that's done by the private sector, with the numbers of patients that we would put through the unit, I don't think it would be able to cover its costs unless the medical aids decide to remunerate a lot more than they currently do for radiation treatment. So, I don't know if it's realistic in the public sector. In the private sector. In terms of the public sector, again, in addition, I'm the head of radiation oncology at Charlotte Mackay, where we have long waiting lists for patients to even have standard radiation. So, whether we should be looking at solving that issue rather than protons at this point, I think we should rather look on the waiting list. We also have this, in addition to equipment issues, there's also a skills shortage in South Africa in terms of medical physicists, in terms of dosimetrists, radiotherapists, which is part of the reason why we have the long waiting list at Charlotte. And a proton center, which I think Dr. Chilukuri mentioned, is that it does require huge amounts of skilled staff to install these units, to keep them running, and that could be also a barrier within South Africa. Not saying that we couldn't develop this, and also with new artificial intelligence technologies, with teleradiation and etc. There's ways around this, especially using the technology. So I wouldn't say it's completely out of the realm of possibilities in South Africa, and it would be great to have it. And I think if we potentially with public-private partnerships, etc., there could be a path to doing this. But I think again, it would need to be a center that would have to be a referral hub for probably the rest of Southern Africa, with a private-public partnership in place, and probably a clever way of doing the radiation planning. And also it would need to serve, I think, as well, because I'm also from WITS, I think it would need to serve as a training hub for South Africans to develop skills as well.
Okay. All right. Thanks, Prof, for that question. Any other?
Thank you. First of all, I came very late, but from what I've heard, a wonderful presentation, and thank you. This is very exciting. I did have a question just for the panel, for all of you, in terms of efficacy of proton beam therapy for treatment of vascular lesions, specifically brain AVMs in particular. If you could comment on that, thanks.
Actually, one of the first indications in Boston, when they started the proton beam facility, in fact, a lot of data comes from protons for AVMs. But in today's world, where X-ray based treatments have advanced so much, I wouldn't really use protons to treat AV malformations. Based on our experience, what we feel is larger the volume of irradiation, larger is the benefit with protons. Smaller lesions really won't much benefit with protons, because there are, as Dr. Ramiah mentioned, some uncertainties, physical and biological uncertainties. We'll have to overcome those. We'll have to give additional kind of margins or insurances which needs to be taken into account, and that kind of is counterproductive. And there would be hardly any difference between proton and X-ray based, high-end CyberKnife based treatments for vascular malformations. Having said that, large vascular malformations, kind of carotid body tumors, which extend from the neck to skull base, those are definitely kind of good indications where proton therapy could be considered. But for small AVMs, I don't see a big benefit with protons.
Thanks very much. Just I'm a vascular neurosurgeon, so that's why my interest. I actually spent a lot of time in the States, qualified there, so I'm familiar with the Boston experience. But I was thinking actually more for the higher Specimen Martin, Specimen Martin 5, patients that we wouldn't even, most of us at least, wouldn't consider resecting,
Yes.
and where gamma knife
Yes.
obviously has its limitations.
Yes.
That was my question. Really.
Yes. So yes, larger ones, the SM5 ones, which probably would benefit with radiation. We could consider on a case-to-case basis, especially these young children. Most of them, when we treat them, they are young, and maybe his risk of secondary cancers. So you're right, in very selected cases, Proton could offer some advantages for large AVMs, where either we could, sometimes these days we are doing fractionated radiosurgery, or sometimes we are doing phased radiosurgery. That means giving 1/2 of AVM for some time and waiting for 6 months and then irradiating the rest. So yes, maybe very, very selectively.
Colleagues, I'm aware that we're running quite late in terms of the program. Let me thank you all of them for having been patient with us up until we came to this point of the evening. Let me just thank once again our presenters for tonight. And I anticipate that this is one of many other collaborative initiatives that the SA Medical Association will be having with colleagues from other parts of the world as we discuss some of these technological advancements and how those could play a role as part of treatment modalities in our country as well. Thanks once again. What then remains for me is just to thank everybody for having been here. Prof. Prof is the president of our association and really heartened for you to have graced us with your presence today. And colleagues, I think it has been a worthwhile evening, and I do hope that you have found something of value. And thank our presenters once again, for those insightful presentations. As I indicated, this is just the beginning. Going forward, be on the lookout. We should be communicating further, collaborative initiatives with our colleagues, from India and other parts of the world as well. Thank you. Okay, Joanna.
I'm not gonna get up there. So
Sure.
thank you so much for coming. This concludes our formal part of the symposium.